Are my
Yes.
slides visible?
Yes, we can see.
Okay. So at the outset, I would like to thank Dr. Naidu, Dr. Koji, and Dr. Yi Yong for giving me this opportunity to speak at this webinar. A disclaimer, I'm an obstetrician and I'm not a cardiologist, unlike most of the panelists. So here we will be talking about pregnancy-related issues and cardiovascular health with respect to pregnancy. So this is the outline of my presentation. Now, in the background, maternal cardiovascular causes, as we all know, are the leading cause of indirect maternal deaths in the developed world. So far, in the developing world, in the LMIC setting, it is rapidly emerging as significant cause of maternal mortality, as we just saw with what Dr. Jayaratne had presented. In India, maternal deaths, the main causes still continue to be obstetric hemorrhage, followed by infection, and followed by preeclampsia and hypertensive disorders. And in our country, in LMIC setting, the rheumatic heart disease is the most common cardiac condition which we still encounter in pregnancy. So how do you optimize? What are the optimization goals? First of all, I think it starts with understanding cardiovascular changes that happen during pregnancy. Preconceptional counseling is very important. Identifying high-risk cases at booking. Then a close surveillance by a multidisciplinary cardio-obstetric team, timely delivery at an appropriate setup, postpartum monitoring, contraception advice, and postpartum cardiovascular risk assessment. Now, coming to cardiovascular changes, so there are many changes that happen in the cardiovascular system of a pregnant woman. The most important ones are being highlighted here. So if you see the blue line that represents the cardiac output, it starts to rise as early as 8 weeks, continues to rise throughout pregnancy, and falls after delivery. The yellow line is the fall in the systemic vascular resistance. The blood pressure, again, it falls and then it slowly rises. So these changes are important for us to understand before we counsel and we understand what is going to happen to a pregnant woman when she becomes pregnant with a heart disease. Now, coming to multidisciplinary approach, a cardio-obstetric team is mandatory for managing such cases because often most of these cases are complex, and it usually is also known as the pregnancy heart team, made up of an obstetrician, a cardiologist, an obstetric physician, an MFM specialist, nursing personnel, OB anesthetist, and neonatologist. Now, coming to preconceptional counseling, I think this is the most important step here. So first, we assess the maternal cardiovascular risk, and we have the modified WHO class. We assess the functional status of a woman. So we discuss the cardiovascular risk, we discuss the obstetric risk in the woman, we discuss the fetal risks that are there, risk of congenital anomalies, risk of hemorrhage if the woman is on warfarin, risk of miscarriages. We review medications that the woman is on. For example, if she is on drugs which are likely to be teratogenic like ACE inhibitors or angiotensin receptor blockers, we change them to drugs with better safety profile. Then we see whether she requires anticoagulation. If she is on anticoagulation, if she is on warfarin, what is the dose of warfarin? Is it likely to cause warfarin embryopathy? Should we change to a low molecular weight heparin? Those are the questions that we need to answer. Now, coming to the WHO classification, all of us are aware of the classes. And we very well know that in class 4, pregnancy is contraindicated. The risk of having maternal cardiovascular event is more than 27%. And therefore, if these women present early on in pregnancy, we need to counsel them about termination. If they continue if they choose to continue pregnancy, they should be followed up in a tertiary care center with a very good ICU backup. Now, there are other scoring systems which have been developed, like the CARD-PREG score and the Zahara score, and the many scores that have been there to fine-tune this. But so far, the only prospectively validated thing is the WHO score. And in the CARD-PREG system, you see that each risk factor or each predictor is given a point. So if the point is 3, that means there is a 15% risk of having a cardiovascular accident event. If the point is 2, then 10%. If the point is 1, then it is 5%. Now, at the time of preconceptional counseling, we see women who have severe valvular disease, for example, they are class 4, then they are advised not to become pregnant and to undergo a surgical correction before they become pregnant. In women who have congenital heart disease, the risk of fetal anomalies should be explained. In women with genetic causes of heart disease, we should talk about genetic inheritance, as some of these can be autosomal dominant. Now, I will be basically talking about valvular heart disease because that is what we commonly see in our country. Now, this was a study which was published recently in the European Heart Journal, where they looked at pregnancy outcomes in women with heart disease. This was published by the Madras Medical College. So here what they found out, this was a study between 2016 to 2019. 60% of the women had heart disease diagnosed for the first time during pregnancy. That's a large number. The most common was rheumatic heart disease still, 42% had. 1/3 of these women had pulmonary hypertension. The most common maternal cardiovascular event was heart failure, which was seen in 66%. Mortality, however, was only 2%, with highest rates being women with prosthetic valves. So here, alarming signs that 60% of them were diagnosed to have heart problems during pregnancy. So valvular disease is the most common cause of mortality and morbidity in the developing world still. Mitral stenosis comprises of 90% of the cases. Stenotic lesions, we know, are poorly tolerated because of the physiology that we just discussed, increase in the cardiac output, whereas increase in the blood volume, increase in the heart rate can all precipitate stenotic pathology. So mitral stenosis, complications include pulmonary edema, atrial fibrillation, cerebrovascular events, and deaths. NYHA class 3 and 4 should undergo surgery prior to conception. If they have already conceived and if they present with failure, which is not amenable to medical treatment, then ideally they should be undergoing surgery, and this surgery is usually done in the second trimester. If they have already had a surgery and they have had a mitral valve replacement, they need to be on anticoagulation. Atrial fibrillation can cause rapid decompensation. The treatment includes use of diuretics, heart rate control by digoxin beta blockers, anticoagulation for stroke prevention because there can be cardioemboli, and hemodynamically unstable patient, even electrocardioversion can be done. Aortic stenosis, not very common, mostly associated with bicuspid aortic valve, better tolerated than mitral stenosis, and treatment for heart failure is the same as mitral stenosis. Now, prosthetic valves is something that I want to focus on because a lot of our women are on mechanical prosthetic valves still. So we know that there are two types of prosthetic valves, and the complications can include something like valve thrombosis, heart failure, stroke, maternal and fetal hemorrhage, and maternal death. So if we compare, this data was from the Registry of Pregnancy and Cardiac Disease by Van Hagen in 2015. So the risk of thrombosis was 6 times more in the mechanical valves in comparison to the bioprosthetic valves. And the risk of mortality was also slightly more than in the mechanical valves. Now we know for anticoagulation, our drugs are warfarin, unfractionated heparin, low molecular weight heparin. While warfarin is the best anticoagulant that is available to us, the problem with warfarin is that it crosses the placenta, hence can cause what is known as warfarin embryopathy in a dose-dependent manner. It can also cause what is known as warfarin fetopathy, wherein the baby has hemorrhage and it can even result in a stillbirth. Unfractionated heparin, low molecular weight heparin, they do not cross the placenta, and therefore the propensity to affect the fetus is not there. Now, here are some pictures of warfarin embryopathy. You can see in the upper panel a binder facies that is mid-facial hypoplasia. These are 2D ultrasound images. And in the lower panel, you can see the white dots, that is epiphyseal stippling. And usually it is seen in 5% of the cases where the dose is more than 5 milligram per day. So the management strategy is usually in the first trimester, if the woman is on high doses, change over to either unfractionated or low molecular weight heparin, then restart warfarin at 13 weeks, continue till 36 weeks. And again at 36 weeks, when you're nearing delivery, change over to unfractionated heparin or low molecular weight heparin, depending upon when you are planning to deliver. Peripartum cardiomyopathy has already been discussed in details with Karen. However, I would like to just present one paper which we had published a few years ago on clinical profiles of women. So here we found out that we had 54 cases over 6 years. The mean age at diagnosis was 35 weeks. Maternal mortality in our cohort was 9.3%. Fetal mortality was 24%. The two most important predictors of poor maternal outcomes were an ejection fraction of less than 30% and presence of cardiogenic shock at the time of diagnosis. These women were followed up till 24 months. However, the follow-up was only done in 40%. I think the rest were lost to follow-up. And when echo was done, it had shown significant improvement in the left ventricular ejection fraction. Coming to congenital heart disease, these are usually well tolerated. One point to remember here is that if the woman has congenital heart disease, the risk of baby having a congenital heart disease is around 4 to 10%. And this is more for left-sided lesions. For things like bicuspid aortic valve, it can even be as high as 18 to 20%. So fetal echo is mandatory in these women. If the woman has already been operated upon, they usually tolerate pregnancy well. If they have not been operated upon, then there can be problems, especially in cyanotic heart disease. There can be problem of cyanosis, hypoxia affecting the baby in terms of fetal growth restriction, risk of miscarriages, preterm birth, or there can be risk of paradoxical emboli with right to left shunt and even lead to stroke. Arrhythmias, most common arrhythmias that we encounter in pregnancy is paroxysmal supraventricular tachycardias. These usually, if the patient is stable, adenosine is the drug of choice. One thing to remember is women who have congenital long QT syndrome, they have a risk of tachyarrhythmias, and therefore beta blockers should be continued throughout pregnancy. Aortopathies, I'm not going to discuss, not a very common cause in our country. Venous thromboembolism, the risk of DVT and pulmonary embolism is 4 to 5 times in pregnancy, and 70% of it is seen in the postpartum period, although the absolute risk is low. Diagnosis is using compression ultrasound. Negative ultrasound does not rule out DVT because in pregnancy, usually proximal vessels such as iliac, iliofemoral are involved. So if there's a high index of suspicion, pelvic MRI should be done, and therapeutic anticoagulation is the treatment of choice. Pulmonary embolism diagnosis is slightly challenging in pregnancy because the symptoms are very similar to pregnancy. D-dimer has low specificity in pregnancy because it rises in each trimester. Definitive diagnosis is based on CTPA or VQ scan, and therapeutic anticoagulation is the drug of choice. IVC filters only if anticoagulation fails or they are contraindicated. Now, coming to the main part about antepartum surveillance. Now, when we talk of antepartum surveillance, that includes fetal and maternal surveillance. Now, if it is a class 3 or a class 4 case, then tertiary care follow-up is mandatory. At the booking visit, we assess the cardiovascular risk. If there are class 4 and it's early pregnancy, we should offer them termination of pregnancy after detailed counseling by a cardio-obstetric team. If they choose to continue pregnancy, they have to have very close follow-up. Functional status using the NIHA classification and the other classifications. We review medications and change over to drugs with say better safety profile. Dating scan to make sure that this is a live pregnancy. Anticoagulation, as I alluded to before, if warfarin dose is more than 5, then we need to change over to low molecular weight or unfractionated heparin. Baseline echo at booking. At each visit, functional assessment is done to see whether there is any deterioration of symptoms. Recording of vitals like blood pressure, heart rate, O2 sats, auscultation of the lung bases. Assessment by cardio is every 1 to 2 months in class 3 and every 1 month in class 4. This is according to the recommendation by the modified WHO classification scale. Warfarin is usually stopped at 36 weeks and we start unfractionated heparin if we are nearing delivery, or if delivery is further away, then we can even start low molecular weight heparin. Fetal surveillance is as usual. Only thing to remember here is 18 weeks, we do a morphology scan. In women with congenital heart disease, fetal echo is mandatory. It is done at 18 to 22 weeks. Women with valvular heart disease, cyanotic congenital heart disease do tend to have growth restriction, and therefore serial scans for fetal growth assessment is required. If the baby is found to be growth restricted, then close monitoring is also required. When do you deliver these women? According to the American College Guidelines, IOL induction of labor should be done at 39 to 40 weeks. According to the European Cardiology Society, the induction of labor should be done at 40 weeks. However, it also depends on a lot of other factors like cardiac status, obstetric complications, and cervical status. For example, in a woman with primary pulmonary hypertension, we often see cases like that who present to us very late. they present at around 22 weeks or 23 weeks, and you can't offer them termination of pregnancy, and they continue, and you have to deliver them by cesarean section at around 30 to 32 weeks. Again, as we said, in valvular heart disease, FGR is a very common complication, and therefore we tend to deliver them at around 37 weeks. Now, mode of delivery. There was a large study by the ROPAC group who actually said that elective LSCS has no added benefit, and vaginal delivery is associated with decreased complications. LSCS should only be reserved for obstetric indications. Cardiovascular specific indications for LSCS: if the woman is on warfarin and she has gone in labor, there is an increased risk of fetal hemorrhage with vaginal delivery. Pulmonary artery hypertension, including Eisenmenger's. If there is aortic root dilatation, then during the second stage, there's a risk of dissection. Acute intractable heart failure. So these four would be the only cardiovascular specific indications for LSCS. In other cases, we try to go for a vaginal delivery. Now, intrapartum care is equally important. Class 3 and class 4 delivery should be done at a tertiary care center with ICU backup. Most common complications that happen in labor are arrhythmias and pulmonary edema. Early diagnosis of labor is important. Women should be nursed in either propped up or ambulating position. Oxygen supplementation where required. Adequate labor analgesia is very important because pain can push them into pulmonary edema. Meticulous fluid balance, again very important. We have to restrict fluid as much as possible to 75 to 80 ml per hour. Close monitoring of vitals. Role of invasive monitoring, again controversial. High concentration, low volume oxytocin for augmentation is what we use in our setup. Infective endocarditis prophylaxis at delivery we do give because most of our women have mechanical valves, or it should also be given in cases of previous infective endocarditis. We do cut short second stage of delivery. Forceps is preferred because in vacuum, again, the woman has to have her own efforts, which can push her into failure. IV Lasix is given at the delivery of anterior shoulder. Now, when the woman is delivering, that is the time when the cardiac output suddenly increases by 30% because the uterus suddenly decompresses, and therefore the pressure on the inferior vena cava is suddenly taken off. So this leads to increased venous return and therefore increased cardiac output. So suddenly at the time of delivery, there's a huge auto transfusion that takes place to the extent of around 30%. So this can push the woman into failure. So we generally do give IV Lasix at the time of the delivery of anterior shoulder. 5 units oxytocin. Now there are certain drugs that should be avoided in management of the third stage, like ergometrin, then PGF2 alpha or carboprost, as we say. Tranexamic acid should be used with caution again because it has got some thrombosis potential. How do we manage women on anticoagulation? If the woman is of high risk of thrombosis, this is a very common scenario in our country. We see a lot of women who might have double valve replacement. That means not only mitral valve, but also aortic valve replacement. In such cases, because they are at high risk of thrombosis, the IV infusion with unfractionated heparin continues throughout labor and is stopped only 4 to 6 hours prior to delivery, or if they choose to have epidural, 4 to 6 hours prior to epidural. Regular APTT monitoring is required. Now, if the woman has got low risk for thrombosis, then it can be stopped prior to IOL depending upon what she was taking for anticoagulation. And then again, it is restarted after delivery as soon as possible. Postpartum care is again important in a labor room setting or in a high dependency unit setting for 24 to 48 hours, depending upon what cardiac condition the mother has. There are significant hemodynamic changes which increase the risk of maternal cardiac event. We need to monitor for risk factors which can precipitate for heart failure at this time. For example, anemia. We need to rule out sepsis, pain. Early ambulation, again, an important thing. TED stockings, because these will decrease the chance of having venous thromboembolism. And we need to restart anticoagulation wherever it is indicated. Maternal cardiac arrest, again, a very sad event that can happen. And maternal cardiac arrest, there is this algorithm for the treatment. We must remember here that if we are not able to resuscitate the woman in 4 minutes of time, and if she is pregnant beyond 20 weeks, then we need to do what is known as a perimortem delivery. Now, contraception again is a major issue in women with heart disease. So here you can see this table, which has been published in Circulation. Now this gives you the list of heart conditions and what are the different kinds of contraceptive things that you can use. So R stands for reasonable and U stands for unreasonable. So if you look at the last column, that is CHC, combined hormonal contraceptives. So these are actually contraindicated for use in deep venous thrombosis or pulmonary embolism, women with hypertension, women with ischemic heart disease, women with metabolic syndrome who have multiple cardiovascular risk factors, women with PPCM, and women with complicated valvular heart disease. The rest of these, like intrauterine devices like Copper-T and other devices, implants, DMPA, depomedroxyprogesterone acetate, these are all basically they can be used for most of these conditions. Now, one important thing that we must remember is that there are long-term cardiovascular risks. So there is something called postpartum cardiovascular risk assessment. Now, which are the women who will require this postpartum cardiovascular risk assessment? If they have had chronic hypertension or hypertensive disorder during pregnancy, like a gestational hypertension or a HELP syndrome, preeclampsia, eclampsia, if they have had gestational diabetes, if there has been history of fetal growth restriction in the pregnancy or idiopathic preterm birth, placental abruption, obesity, excessive weight gain during pregnancy, obstructive sleep apnea, or if the mother's age is more than 40 years. So these are the women who need to undergo this postpartum cardiovascular risk screening, where a detailed medical history is taken, physical examination is done, and some tests are done. So medical history includes risk of smoking, breastfeeding, family history of cardiovascular disease, etc. Physical examination, blood pressure, heart rate, BMI, and waist circumference is checked. Testing for total cholesterol, lipid profile levels, fasting glucose, urine assessment, and nutrition assessment are done. So what happens if a woman has a borderline value or an elevated value during this evaluation? Then she is put on a lifestyle modification program, which runs for 6 to 12 months, and then these are reassessed. And if at the end of 12 months, they are again they go through the entire risk assessment again. And if the findings are still abnormal, then pharmacologic therapy is initiated. So the take-home messages are preconceptional counseling helps improve pregnancy outcomes. Early identification of high-risk cases. We should offer termination of pregnancy following detailed counseling. In case the couple chooses to continue pregnancy, antenatal care should be given in a tertiary care facility. Cardio-obstetric team should be involved in the antenatal care. Both maternal and fetal surveillance are important. Timely delivery in a setting with an appropriate infrastructure is of paramount importance. Postnatal cardiovascular risk assessment and lifestyle modification will help decrease morbidity and mortality due to cardiovascular issues. Thank you so much.